Well, good morning, all, and welcome to today's Medical Grand Rounds. Happy New Year, an exciting first talk for 2025. So we'll go ahead and get started with some reminders, some logistics, and then get right into introductions. Next week, be sure to join us. We will be hearing a talk about long COVID and chronic fatigue syndromes given by Dr. Becca Kennedy. That will be virtual only, as is today's talk. And just as a reminder, due to strike at Providence St. Vincent, we will be available only virtually through at least the end of January. Grand Rounds is a collaboration between Providence St. Vincent and Providence Portland Medical Centers. We often meet live on Tuesday mornings at St. Vincent and sometimes at noon at Prov Portland. We are always here on Teams Live, and you can learn where we'll be on the Grand Rounds invite each week. You can earn CME credit by being in the room, by watching live virtual, or by watching a recording of the event. And that recording is also always available at the same link as the Grand Rounds invitation. I'll be monitoring the Q&A throughout today's session, so please go ahead and post any thoughts or questions you have online, and I'll mostly hold those until the end as time permits. And now for introductions. Today is indeed a special Grand Rounds. It is the Dr. Richie Warnick Lectureship in Medical Education. Dr. Warnick, as many of you may know, joined Providence Portland Medical Center in 1981, where he remained on staff for a remarkable 37 years. He educated and mentored countless residents, medical students, and faculty. Many patients have had their care touched by Richie without ever having known his name. And in addition to direct teaching of trainees, he took great pride in his role in continuing medical education, certainly was a mentor to me, and helped bring the highest quality of education and professional development. He was humble to a fault, and yet recognized by a multitude of clinical and teaching awards. Richie's love for medical education was only rivaled by his love of music, dogs, and of course, baseball. And it is in his honor that I am delighted to welcome today Dr. Adam Brodman, a general internist and medical educator at the Beth Israel Deaconess Medical Center and an assistant professor at Harvard Medical School. He's the director of AI programs for the Carl J. Shapiro Center for Education and Research, and he leads the task force for integration of AI into the medical school curriculum. He is also an associate editor at New England Journal of Medicine AI. His research focuses on medical education, clinical reasoning, integration of digital technologies, and human-computer interaction, especially with AI. His first book is entitled Shortcuts, Medicine, and he is the host of the American College of Physicians podcast, Bedside Rounds. Adam completed his residency in internal medicine right here in Portland, Oregon at OHSU, and then his fellowship in global health at Beth Israel Deaconess Medical Center while practicing in Botswana. He lives in Boston with his wife and 2 young sons. Adam, what a delight. We're so happy to have you with us today.
Oh, well, thank you for having me. I mean, obviously, Portland holds a very dear place in my heart. So I'm incredibly excited. Also, I hope that someday somebody also recognizes me for my love of dogs. Dogs, best animals on earth. Maybe that's controversial if you're a cat lover, but 2 thumbs up. My dog just passed like 2 months ago, and like all the time, I'm just like, dogs. So very excited to talk to everybody today. I am, this is a weird way to introduce myself. I'm kind of a strange person. So I'm a medical educator. Like I'm brought up as a medical education researcher. And because of that, something that we do in medical education, like if you fundamentally think about what we do in medical education is we try to understand and improve how people think and how people make decisions. And that was always a focus in my research. So now I've made this bizarre transition fundamentally like an education researcher to being an artificial intelligence researcher, but in this cognitive domain. The big conflict of interest that I want to tell everybody is that I'm also a visiting researcher for Google. However, right now, not Google employee. This is Adam, like Beth Israel, Adam, general internist, not Google researcher speaking. I think I do have one reference of a Google technology in here, but that's just the COI that I want to get out from before. So I'm going to be joined today by Dr. Schaefer, Alex Schaefer, So the way that I'm going to structure this presentation is I want to really go over our understanding, like the scientific and psychological understanding of how doctors make decisions. Then I want to talk about why language models are very exciting in this field. And I'm a believer in showing, not telling. So Dr. Schaefer is actually going to join me, or Alex is going to join me in a example from one of my own studies of what this actually looks like in practice. So we can look at how human-computer interaction with these powerful technologies works and what some of the downsides actually might be. So with that, thank you for having me, and let's get started. So, clinical reasoning. What does it mean to make a medical decision? What does clinical reasoning mean? And there's a study that I love from, I keep saying it was just published. It was published almost 20 years ago, which just shows how old I'm getting. But if you ask 12 different researchers, what is clinical reasoning? What does it mean to make a medical decision? You're going to get 12 different answers. And this is part of the historic problem of how it's been so difficult to define what it means when doctors make decisions, and then from an educational perspective to evaluate it. So for example, you could do a task-based kind of classification. This is from Bordage almost 20 years ago. Oh no, no, it's not that. It's not quite that old. Only 12 years ago, but this is based on much older work that Bordage did. Looking at the number of different cognitive tasks, Bordage identified 24 different psychological tasks that a primary care physician does in a single day. So part of the problem when we talk about artificial intelligence and clinical decision making is there's a lot of different types of decisions. Now, at its most kind of fundamental, most simplistic view, diagnosis, the clinical reasoning is the process of diagnosis, and diagnosis is this. It's why I wrote this as the inverse of nosology. What is nosology? Nosology is how we characterize or categorize disease. So if you want to go back to the very kind of fundamental basics of diagnosis, it's a classification task, and it's a classification task where you pick a single disease from a list of from a list of diseases, or you pick several different diseases, a differential from a large list. Now, anyone who practices medicine knows that this is a gross oversimplification of the cognitive work that we do as physicians. And right now in the year 2025, and I would say really since the early 2000s, the dominant explanation has been mired in cognitive psychology. So as a review for those who may not have reread Thinking Fast and Slow, like R.I.P. Danny Kahneman, I actually, after Danny Kahneman passed last year, I reread Thinking Fast and Slow. I do not recommend that anybody read it. It's so funny. In my memory, it was such a mind-blowing book. But if you reread it, it's like 800 pages. He's a brilliant man, but he makes the same argument again and again and again, and it's not very well written. Sorry, Danny Kahneman. But Danny Kahneman, Amos Tversky, and the field of cognitive psychology basically argue that there are two fundamental cognitive processes that happen in our mind. There's system one. System one is very fast. It is automatic. It is efficient. It is based on heuristics. It is very, has a tendency towards bias. But it's most of what we do. And then system two is slow, deliberate. It is theoretically acontextual. And it is very laborious. People don't like to do system two thinking. And don't worry, I'm not going to explain this whole thing, but the basic modern understanding of the diagnostic or the reasoning process is that there is an interplay and crossover between system one and system two. This actually came out of the work of Elstein, really in the late 1970s. Elstein is the researcher who really defined this idea of the hypothetico-deductive process, right? This is the Sherlockian hypothesis testing, branching as we exclude hypotheses. And he tested this out, and actually here in Boston, on groups of medical students and groups of attendings. And what he found is that if you have people think out loud and you give them a case, both the medical students and the attendings will do the same thing, right? They will model the Sherlock Holmesian, what could be going on? How am I going to hypothesis test? What's the next step? But Elstein found something quite curious, which is the medical students would ask dozens and dozens of questions, and they wouldn't be terribly accurate. The attendings, however, would sometimes only ask 3 or 4 questions, and they would much more frequently get the right diagnosis. So this late 70s, this is, a few years after Kahneman and Tversky published their seminal work, but he was the first person to realize, there's something else going on inside the clinical brain that explains clinical decision making. And I'm going to explain, I think, the dominant unified theory right now, which is script theory. So script theory, this is now actually taught in medical schools. Actually, it's very popular in Portland because Judith Bowen was at OHSU for years, and now she's at UW. But script theory is a knowledge organization theory, and what script theory posits is, okay, well, doctors gain knowledge from many different sources, right? They get it from medical school, they get it from their reading, and more importantly, they get it from their patients and seeing lots of patients. And then doctors have to store this information in their brain. And doctors do not store the information like the Dewey Decimal System, right? It's not a J.75.XL is heart failure, and then heart failure reduced. It doesn't work like that. But doctors store in complex sets of associations that are called scripts. And this, again, comes from the psychological literature in the 70s on scripts are like stereotype behaviors. The classic example is that if you go out to eat at a restaurant, we have a specific script, but if you go over to your friend's house and you try to follow that script, it's going to be like very socially unacceptable. So that's where the idea of scripts comes from. And Judith Bowen is the one to popularize these ideas, again, based on a lot of the work of Bourdage. But we store exemplar examples of diseases in our brain. And we teach like this all the time, right? We talk about semantic qualifiers. Is the presentation acute? Is it subacute? Is it chronic? Is it polyarticular? Is it monoarticular? And we have all of these different comparing and contrasting on how an exemplar disease will present. And then the next big insight in script theory is we don't just activate a single script. Scripts exist in contrast to each other in these large networks called schema, where almost by definition, by deciding something, we exclude something else. Okay, so what does this look like? This sounds very theoretic. So what does it actually look like in practice? So I see a patient in my clinic. She's saying, I can't breathe. It started yesterday. Everyone has had this experience, especially the more experienced we get. You start talking to a patient and automatically diagnoses start coming to mind. In this case, her presentation activates something called a problem representation, acute dyspnea, which instantiates, without me thinking about it, my kind of script for acute dyspnea. This then feeds back into the questions that I ask. And, if someone has acute dyspnea, I'm going to hypothesis test other things in that schema. So COPD, pneumonia, and I'll ask those questions in a sort of iterative process until I come up with a diagnosis or list of diagnoses, or until I encounter something that I don't expect that has me cross over to a system 2 thought process. So this is script theory. It is a knowledge activation theory. And until maybe 2015 or so, it was the dominant understanding on how clinicians made decisions. Now, right now, I am sitting, I was interviewing applicants all morning, so I'm sitting in my home office / guest room. I've had a lot of coffee. If I were at work right now, my mind would be great. I am ready to take anything. Everybody has been in the situation where it's not, well, for me, it's 11 a.m. For you guys, it's 8:15. But where it's not the morning and you're well caffeinated and well rested, everyone has been, after a very busy day of clinic, your last patient comes in at 4:45 and your mind is not working the exact same, or it's 2 a.m. and my pager keeps going off, or we just went to Epic. So Epic Chat just keeps going off. So I think all of us intuitively recognize that our decision making is not always the same, depending not on internal factors, but depending on what's happening around us. And this is called ecological psychology. And this is a very dominant, again, in medicine, doctors are, to put it nicely, a little bit arrogant, and we like to think that we're special. So ecological psychology is something we've known in other fields like aviation and industrial safety for decades. But in the last decade, we've gotten a lot to talking more about the psychological impacts of the world around us. And everybody knows being a doctor is really stressful. There's a lot of distractors and a lot of things that can throw off our reasoning. There's also this argument actually is very popular from some scholars up at the University of Washington, so in the Pacific Northwest. The idea that reasoning, our decision making, is context specific. And the idea here is that while we might pretend like I could be transported to any other place and make the same decisions, there's so much about the place that I've been trained, the diseases that I've seen, that dramatically affect the diseases that I see. So I was recently, I have some collaborators in Chile. I was in Chile doing some work, and they brought up the idea of hantavirus. And to me, yeah, I've learned about hantavirus, but I've never seen it, and I don't have any cultural context for that. Same as if my colleagues came to Boston and saw babesiosis, they would have no context for that at all. overall. And then finally, in my field, one of the biggest domains, by the way, you can tell this is AI generated artwork because these Simpsons characters have demon faces. But one of the biggest influential psychological ideas in the reasoning field in the last few years that I think is the most important is this idea of distributed cognition. So if I think, like if I'm working in the hospital or on Monday I'm going to work in the emergency room, when I'm making decisions, I'm basing my decisions on data that might have been collected by the patient's primary care doctor months ago. And I might have a hypothesis, but it might not be confirmed by that patient's outpatient rheumatologist for another couple weeks. So we are largely making decisions. It's not that we're talking with other doctors, but we're basing it on reasoning of other human beings from other specialties, not just physicians, and we're all mediating this through the record. And this is called distributed cognition. And I think it's one of the most important psychological ways to talk about when we're talking about human decision making. So how do we make people think better? Like fundamentally, if you want to break down what the role of the medical educator is, it is to make new doctors and hopefully to improve our clinical reasoning, our ability to make decisions about our patients. I mean, there's a lot of other important things we do, like communication, empathy. Those are all incredibly important. But, you know, clinical reasoning is the raison d'etre of medical school. And if you look historically, there have been three large categories to make people better at making clinical decisions. Number one, this was very popular when I was a resident, is educating people about cognitive biases. If you've ever been in a lecture where they tell you about, oh, this is anchoring bias, this is recency bias, this is why you made a mistake, then you've been through these, you've witnessed this educational strategy. They've become less popular in recent years for a very good reason, which is they don't work. So educating people about cognitive biases does make them more aware of their cognitive biases, but it doesn't decrease errors. And if you want to think about it this way, like this is how I put it. 4 years ago now, I made a brilliant diagnosis in the hospital. I diagnosed somebody with Mycobacterium bovis because they had had a BCG treatment like 6 or 7 months for bladder cancer. And everyone was like, oh my God, Adam, you did such a good job. That's such a great diagnostic job. What I didn't tell anybody is the reason that I recognize this entity is a couple of weeks before the New England Journal of Medicine had a clinical pathological case conference where the diagnosis was M. bovis because of BCG treatment. But I was just anchoring on something that I had read, or a recency bias. Like I was using a cognitive bias. But because that heuristic worked, no one was like, oh, you shouldn't have done that. They were celebrating me for being a brilliant diagnostician. And this is part of the problem. Heuristics are just part of the way that humans have evolved. It is a way that our mind evolved because of the environment in which we evolved in. And heuristics are just something that we do. So unfortunately, educating people about cognitive biases doesn't make them less likely to have cognitive biases. So number two is debiasing strategies. Now, this is a strategy that works. So right now, if there are any residents here, if I were to tell you that you need to spend 1 day a week following up on all your old patients, calling them, looking at the charts, seeing how they did, it will make you a better diagnostician. There is good evidence in the literature that these sort of debiasing strategies work. Another classic one is if every time a patient decompensated in the hospital, we stopped, we did a diagnostic timeout, went over all the information, and then rethought what we were going on, we would make better decisions. I think it is not hard to understand why these things in studies don't translate to the real world, which is, I don't know about you, but around in Boston, doctors work all the time. There are not 8 hours in a week. There is, when a patient is decompensating, there is often not time for robust diagnostic timeouts. Even something relatively simple. There was a study recently that doing a timeout before doing an intubation drastically improved intubation quality. And I believe that the coaching was like 8 or 9 minutes. But if you think about an ICU, how little time they have, there are real costs of time of all of these things. So unfortunately, while experimentally these things work and they're psychologically sound, they are difficult to implement in practice, which brings us to artificial intelligence, which is ironically the oldest improvement strategy. I always love this quote because I want to always remind people that AI is something we've been talking about in clinical reasoning basically as long as we've been talking about reasoning. So this is a quote from Bernard Shaw. If you'll notice the date, it is 1918. So he's reflecting on how everyone used to do math by hand, and now people use counting machines. And he says, in the clinics and hospitals of the near future, we may quite reasonably expect that the doctors will delegate all the preliminary work of diagnosis to machine operators, as they now leave the taking of a temperature to a nurse, and with much more confidence in the accuracy of the report than they could place in the guesses of a member of the RCP. The observation of the symptoms is extremely valuable, depending not only on the personal condition of the doctor, who has possibly been dragged to the case by his night bell after an exhausting day, but upon the replies of the patient to questions which are not always properly understood, and for lack of the necessary verbal skill, could not be properly answered if they were. From such sources of error, machinery is free. So this is what I love. You read this, and you're like, this is how we talk today, right? He's already identifying the cognitive load of the medical system, the difficulty of getting consistent answers, and asserting that machinery would do a better job than humans. And, this sort of language can be seen with Silicon Valley tech bros talking about medicine today. I know, because some of them really like to argue with me in social media. And one of the things that I always like as a historian that I always like to point out is that, well, historically, AI was really helpful. We talk about AI as if it's something that is new, but you go back to, depending on how you define artificial intelligence, the first medical AI was invented about 6 months after the first electronic computer was invented. So from very early periods, this is something that we've been working on. And there are some really, really cool AI systems that did a great job. AAP Help is the Leeds abdominal pain score. It cut mortality in acute abdomens in a multi-center RCT by 22%. Really quite impressive. And then Internist 1, if anyone knew Jack Myers, if anyone is in their 60s or 70s and knew Jack Myers, he was the chair of medicine at Pitt and the president of the AMA. He had an eidetic memory, what is that called? Photographic memory. Brilliant man. So I have been told the reason we no longer have oral boards exams is largely because of him. His nickname was Black Jack because people hated having him as a oral board examiner. But he joined up with a computer scientist to program a computer version of his brain in the 1980s that could solve New England Journal CPCs better than people. So these are not new technologies. However, they kind of stalled out in the early 1980s. There wasn't much improvement basically from the 1980s into the early 2010s. And in the history of AI, large language models are the most exciting intervention that we have had in multiple generations for clinical reasoning. So at this point, probably everyone has used ChatGPT, but to talk about what a language model is and why it might matter so much for reasoning, language models are neural networks that are comprised of basically all the text on the internet and a ton of pirated books. This is the script to Star Trek II: The Wrath of Khan. I'm a huge nerd and Star Trek fan. My 4-year-old wanted to watch The Trouble with Tribbles last night. It made me so happy. And what it does, same the way that Google works, right? You type in something like internal medicine physicians are, and it comes up with a word, probably nerdy, but a word that has been predicted from all the previous Google searches. Large language models do this hundreds of billions of times, and for every single token, which is a part of a word, in a vector string, so in a sentence, in a paragraph, increasingly in a book. So you get this massive word prediction algorithm. And now humans, I study reasoning, so I guess I can say humans are both wonderful creatures and terrible creatures, right? We wrote the Declaration of the Rights of Man, we wrote the Torah, we wrote the Bhagavad Gita. We also wrote Mein Kampf and the website 4chan. So all of these language models undergo a fine-tuning process where humans literally say, that is good, that is bad. It is a Skinner box. And then over time, the algorithm learns not to spit out horrifically racist, sexist, or terrible or inaccurate things, though, of course, they still do spit out those things occasionally. And, when you do this, you get something that is remarkably a simulacra of human reasoning. This is Star Trek II: The Wrath of Khan. I told it to make it like Shakespeare so that he could understand. And he says, "Farewell, noble admiral, hold not your breath. The Enterprise cannot save. She's marked for death. From the skies soon shall be torn asunder. A fiery end, a final echoing thunder." And yes, I did just do this so I could do the Star Trek meme with Khan, but also to raise the point that these can be used for anything. That video at the beginning was made with actually a Chinese AI algorithm. I have another one from Sora, which is the OpenAI video algorithm. This is just DALL-E 3. The American College of Physicians, I'm not going to have time, but I could show you, made me create an AI version of myself that looks and sounds and has all the hand motions of myself, which really freaks me out. It even does the glasses thing that I always do. So anything that can be broken down into fundamental units can be, by one of these transformer algorithms, basically recreated. Why does this matter for reasoning? So we'll talk about this more, but this is the patient I mentioned who I made the M. bovis diagnosis. And if you put this patient's, basically my thoughts at the time, into a language model, you get something that is remarkably similar to human reasoning. And in this case, it gets the diagnosis right. And its number 2 thing on the list was the second diagnosis that we were all thinking about. So language models, because the clustering of tokens is very similar to how script theory works, right? To how humans cluster semantic modifiers, it gives you a simulacra of human reasoning at scale with far more encoded information than we ever could. That gives the models, first, remarkable diagnostic abilities, and as we'll talk about when I get to the third part of this talk, it gives some pretty scary management abilities also. So, Dr. Schaefer or Alex, are you ready for a presentation of reasoning or an example?
I am ready.
So for everybody else, what I'm going to do is right now at the BI, you come into our emergency room. We're not doing this live, it's all retrospective, but a system ingests all of the clinical data that you have, and then we have a secure compute cluster that generates second opinions. So what Alex is going to do is to walk through, this has been stripped of all PHI, but to walk through an actual emergency room patient. There's nothing fancy about this in real time. And Alex is going to give us his thoughts about what might be going on and what tests you would want. And then we're going to ask the AI. And Alex, after each step, I kind of want you to reflect on what the AI itself says and how that might affect your thinking. You ready?
I am ready.
So this is the triage. So, this is the patient having seen the triage nurse, and the nurse just put this information in. So chief complaint, chest pain, tachycardia. Patient reports a new PE diagnosis and left lower extremity DVT at an outside hospital emergency room. Started on Eliquis 10 BID since 4 days ago. Now the patient has come in with worsening chest pain, cough, and tachycardia. The nurse put this patient as the highest emergency severity index, so doctor comes immediately. And then the patient has a fever of 101, heart rate 140, respiratory rate of 26, and you can see the rest of the vitals. Stable blood pressure, normal oxygen. What are your thoughts?
My goodness, very broad differential here. I'm worried about incomplete treatment of his pulmonary embolism. Was he taking his medicine? I'm a little suspicious that even if he has a recurrent pulmonary embolism, that might not explain his fever, although I suppose that it could. I'm wondering if this is the presentation of some underlying disease that caused his PE 5 days ago, but the differential is really broad here. I think I would go with that. I might want to know how old the person is, which you have.
Oh yeah, I'm sorry, I took that out. The person is young. This person, I believe, is about 30. I had to do safe harbor criteria, so I had to strip their age. Okay, so the AI system, were it to, and I'm using a COT prompt here, but the AI system would also agree with you that the most likely thing is recurrent or worsening PE. It is also suspicious of that fever, thinking about other processes such as a pneumonia. It is considering, and it also doesn't know the age of the patient, but ACS is on its differential, pneumothorax, pericarditis because of the chest pain and fever, I think. And then it's got some dangerous but far rarer things like aortic dissection, pulmonary infarction. So similar to you, it has a very broad differential. My question for you, Alex, would any of these things that the AI is spitting out, is this helpful, or it sounds like, what are your thoughts? Would this change your behavior at the moment?
No, I think I can honestly say all of the things that the computers mentioned here has kind of been in the back of my mind as possibilities here.
Perfect.
I don't think I would have forgotten to think of any of those things so far.
So on to the next aliquot information. So again, the context, we'll do both of them at the same time, the next two. So this is the resident who has now been sent to see the patient, and the resident has taken the additional history and done an exam because this patient was triaged at the highest level. So young female, I believe she's in her 20s, I just took out the age, presenting to the ED for chest pain and worsening shortness of breath. History of a lupus, diagnosed with a PE 5 days ago after having a CT for shortness of breath and chest pain, started an Eliquis 10 twice daily, which she has been taking regularly. And then just today, worsening shortness of breath, chest pain, and palpitations, which made her come to the ED. And then everything else you already know. And then I'll give you this additional information, which is the resident's exam. So the resident did not document an abnormal exam other than the vital sign abnormalities that we already know.
Okay. More comment here. Well, I'm very interested in an EKG to look at that heart rate, whether that is secondary to her underlying system or whether she has some primary arrhythmia, perhaps, that we need to manage acutely, whether that's a complication or the primary cause of her underlying problem. I have forgotten what her O2 sat is.
It was completely normal.
Yeah,
she was 99 on room air.
Yeah. I think a stat chest X-ray would be helpful here. We're still looking at such a broad differential for this person. The fact that she has lupus makes me more worried, but somehow not specific. It almost might be a distraction as I find myself thinking about complications of lupus. I'd be more worried that we're missing something more basic, like she didn't take her medicine and has recurrent PE, acute coronary syndrome. Perhaps she has inflammatory or kind of an autoimmune coronary artery disease. I guess that raises acute coronary syndrome a little higher on my list, even though she's a young woman. That's where my mind is going. EKG and a chest X-ray stat would be helpful here.
Both you and the AI want an EKG. I'll have to give the apologies, which is this gets to the nerdy data science reasons. My system pulls in from Snowflake, and EKGs and the reads are stored in a separate database. So currently we're not pulling in the EKG. I do know what the EKG showed. I believe the initial EKG was normal. It certainly did not show ACS.
Okay.
So both you and the AI will be disappointed because they want the EKG. So the AI is actually remarkably close to you, right? It's saying the most likely thing, we're worried about recurrent or worsening pulmonary embolism, with pulmonary infarction being on there, which I think is completely reasonable. It still puts pneumonia on the differential, pericarditis, lupus pleuritis, both of this reacting to this new information about lupus, and then putting ACS, pneumothorax, aortic dissection, these like very things that you would pick up relatively easy with tests high up there. And Alex, does this change your thinking at all? Is it helpful, not helpful, or just doesn't move it?
No, it kind of validates for me that I need to be focused on the most dangerous things. So if she has lupus pleuritis, I'm not sure I care about that in the next 5 minutes.
Perfect. So I imagine you would probably get the same test that actually happened, which is the chest X-ray. So chest X-ray was performed, likely small bilateral pleural effusions and atelectasis. Component of infarct cannot be excluded. Again, to be explicitly clear, my system is not pulling in from the PACS yet. It's just pulling in from the reports that are in Epic. The CTA was performed, a right lower lobar and segmental pulmonary emboli with no right heart strain, small pericardial effusion, a trace left pleural effusion, and then large lymph nodes and this hepatic hypodensity. And then a formal echo was actually performed, and it was pretty normal. Reduced global longitudinal strain, normal diastolic function, no valvular pathology, indeterminate pulmonary systolic pressure. So pretty much a normal echo. As we wait for the computer to ingest these, does this change your thinking in any way?
Well, it makes me less worried about a lot of those most dangerous things that we see there. I don't have a sense of these, whether the pulmonary emboli we're seeing are old or new.
They didn't at the time either. We didn't have any records, which is one of the reasons I chose this patient.
So that's a little bit concerning. The possibility that we haven't ruled out the possibility that she has somehow, for some reason, failed treatment of the pulmonary emboli that she had 5 days ago. Boy, I'm not sure what I would do next if I knew she had failed that. Perhaps I'd consider heparin, but I think I would do that only after getting a little more confirmation that she had failed the treatment. So I'm a little more relaxed. She doesn't seem to have tamponade. She doesn't seem to have an ACS, as best I can tell right now, although some troponins might be helpful here. I might look at, some database to, I have my Harrison's textbook from 1991 here, which I refer to often. So, yeah, well, I feel like I have a little bit more time. Maybe she's just got a brewing influenza or brewing pneumonia that we aren't seeing yet on the CTA. EKG you said showed a sinus tach, is that right?
EKG was no ACS on the first read, with some small T-wave abnormalities in all leads.
Some small T-wave abnormalities.
Yeah, though unfortunately that's not pulled into my system, so that was Adam cheating and looking personally at the case rather than what was in.
I mean, I might have to consider just broadly sepsis. Some labs might be helpful here. And considering treating her for sepsis while I'm figuring out what else is going on.
Well, I will go over what the AI did, which is, again, remarkably similar to you. If you look at this, the AI is saying the same thing as you. It looks like either recurrent or just unresolved PE without knowing the comparison. Again, considering pulmonary infarction. And then it's putting the lupus, serositis, or pericarditis higher up there. But you can see a lot of those, it's really mad at me for not having an EKG, but a lot of the scarier things have dropped off because, again, like you, it's identifying that those scary things have largely been ruled out. Alex, does this change your thinking, or what does this do to you cognitively, seeing this information?
So seeing what the computer says, I guess, is validating in this sense. I think I'd be looking to AI to help me make sure I'm not forgetting some terrible thing, or that I'm not seeing something obvious that I've missed. And I don't think that's true. I guess I haven't yet said the words pulmonary infarction, so that was helpful because that was in my brain here as, oh, this could just be evolution of this PE that she had 5 days ago. But I didn't really say those words, so I have to admit that the computer was helpful there.
So we'll go over the laboratory data. So this will be, and again, the way we predefine diagnostic touch points based on times that doctors access the information. So we are actually seeing things in the order that the doctor reviewed the information. So normal lactic acid, mild hyponatremia, but it looks like otherwise a pretty normal BMP. Calcium is, I think that's normal. Normal liver function test. Pro-BNP is normal. The troponin is highly sensitive, so that's normal. She's anemic, right? Hemoglobin is 9.1. The MCV is 81, so normocytic anemia on the low end of that. But otherwise, normal CBC. Diff is normal. Her INR is 1.7, and the PTT is 35. So that's, I think, indicative that probably was taking her DOAC. And then pregnancy test negative, UA, I think this is normal. I know they repeated the lactic acid and the troponin for some reason, both of which continued to be normal. Do these labs change anything for you?
No, they really don't. I'm left with, gosh, she must be sick with something. And if this is a brewing pneumonia or influenza, again, I'm not sure I care in the next 5 minutes, given her vital signs. I think what I care about most is this possibility of persistent, of untreated PE. I go back to this question of maybe she needs heparin. I don't remember how effective DOACs might be in the setting of lupus with pulmonary emboli, and so I might have to look for some information about that. Could that be a sort of a concrete way that she was getting ineffective treatment?
Yeah, and as you can see, it looks like the AI is basically agreeing with you that persistent recurrent PE, number one, still loves pulmonary infarction, I think probably because of the fever, lupus serositis, and then the pneumonia, right? Is still considering that maybe it's a early brewing pneumonia. I think it's going to continue to say ACS until I give it a normal EKG, which I don't have. So my guess, I can put words into your mouth, this probably doesn't change your thoughts because it basically says it didn't change, right?
I think that's fair.
Okay. All right, so I'm just gonna, I'm not gonna read this because the final touch point in our study, this study only goes to admission. It's an emergency room study. So the medicine doctors eventually came and saw this patient, and the medical intern took a very detailed history and found out that this happened again or prior 6 years ago. Sinus tach, pleuritic chest pain. At the time, she was evaluated by cardiology, had a small pericardial effusion, and they ended up, it went away on its own. They did nothing else. And then prior to this admission, she started having those symptoms again before the acute shortness of breath. And she was having high fevers. Her outpatient rheumatologist was treating her for a lupus flare, increasing her methotrexate dosing. And then the medicine intern got this, which is the med she was on. So she was on a newly high dose of methotrexate and had recently been started on apixaban and had missed no doses.
So she was treated in the past for a similar syndrome that was thought to be a lupus flare. That's vaguely reassuring, but again, my alarm bells are going off that that can be very difficult information. Patients can have, they can report this is just like the last time, and then you go back and read the chart, and in fact it wasn't. And the biggest mistake I could make here is missing something new and more dangerous. Not sure where that leaves me here.
Has your differential changed at all? Do you still think, is it basically the same without additional information?
I think it leads me down that direction, but I still find myself wondering if we have treated her pulmonary emboli. And I'm trying to figure out how we might sort that out.
And if we look at the AI, it's telling basically the same thing, right? It is effectively saying this still seems, incomplete resolution or extension of the PE. It's really not moving that much. I think this is the first time it's mentioned combined PE and lupus serositis as a mixed picture. But ultimately, this differential is remarkably similar to what came before. Do you want me to tell you the final diagnosis?
Well, sure.
Yeah, so both you and the AI are correct, right? So ultimately, at the time, they were worried. They were like, we cannot rule out if this is extended or not, because they didn't have the old imaging, so they heparinized her. Then they got from the outside hospital the imaging pushed over and saw that, if anything, the PE was actually a little bit smaller. And the final diagnosis was lupus serositis causing a pulmonary embolism, with a resolving pulmonary embolism, and that her symptoms at that point were actually driven by the lupus flare, and that the PE, which was resolving or slightly smaller, was caused by the lupus flare itself. So here's my question for you, Alex. You did great. Clearly, you do not need an AI system, but I want your experience. This is O1, right? So O1 is a pretty powerful system. It is a quote unquote reasoning system. Did it help? Like, what did it do to your thinking as going through the case?
I think it made me worry less. I actually found it to be helpful there in that regard. My relatively modest experience with AI in a variety of different circumstances is what I love the most about it, is that it reminds me of things that I hadn't thought of before. I searched for quiet places to put a kayak in the Columbia River some time ago, and although I've lived here for 40 years, it showed me 3 places I didn't know existed as an example. So this was kind of helpful in that way. And it helped me also put some concrete words on things that were in my mind, but that I hadn't expressed very clearly, like pulmonary infarction.
So what you felt it did best is you were good at triaging, but it helped to make sure that there were items that either you hadn't explicitly thought of, but were kind of implicitly thinking of, or maybe some things that you hadn't thought of in general.
Yes.
All right. Well, Alex, I wanted to thank you for doing that, for being for doing a live demonstration of a mystery case, which, and then for everybody else, this is just it's not random. Like I loaded up one day of our data, read through about 20 cases and picked the most interesting one. But this is not, like, I did not pick this case to be difficult. I just picked one of the like thousands of cases that we had. So Alex, that was real. Thank you so much. You did an amazing job. So thanks.
Thank you.
All right. I now want to go over a bit of the data, which is interesting that Alex's intuitions are basically similar to what the data shows. So we'll start with things that I don't care about. LLMs encode so much human knowledge, so much medical knowledge, that they can pass basically any board exam like that. I don't really think that's meaningful. LLMs are also amazing, as we can see here, at generating differentials, and this continues to improve over time. The human baseline is in brown at the bottom. These are just solving New England Journal CPCs, which again, those are really rare cases. I don't know what this means, except that you can see a very clear improvement with like previous generations of technologies. The current quote unquote reasoning technologies are by far the best differential solvers ever invented, including humans. Now, this is where things start to get interesting. LLMs, as you can tell, have emergent probabilistic reasoning. It is not epidemiological reasoning, right? They're not reading through the medical chart and saying, okay, this is what happened in 2022. We had this many cases of lupus serositis. But for some reason, the relationship between words gives it emergent probabilistic reasoning that, again, is not perfect. And the reasoning technology actually doesn't seem to make much better, but it's better than humans. And this probably accounts for some of their ability to make diagnostic decisions. it is able to display clinical reasoning. So again, this gets to its ability to role play or cosplay, whatever you want to call it, a physician. If you give it mystery cases that unfold over time, like a real case, and then you ask it to do problem representations and differentials, like everyone does pretty well, but residents do the least well, attendings do a little bit better than the residents, and then the AI does better. And there's no difference in efficiency, accuracy, quality, cannot miss. And there's not much more, but incorrect reasoning. The model hallucinates more. It says things that are not accurate. Now, if you look at the reasoning technologies, and I guess I should have explained what these are, but if you look at O1, and I'm sure that O3, the new model, or Gemini 2, which uses these reasoning technologies, it just keeps getting better. So if you look in the upper left-hand corner, that's O1 on this same task. You can see it's basically perfect. Like 10 is as good as you can get for the display of reasoning. Residents, the humans, are the two bottom ones. And similar with cannot miss diagnoses, even though there's no statistical difference, you can clearly see that trend is going in the direction of the models getting better and better. Some of the controversial things that I want to talk about are what we just witnessed, which is Alex working with an AI. So the fundamental precept, really since, I don't know, the 70s, even though it's Kasparov who really said this in the 90s, the fundamental precept is that humans plus AI will always be better than humans or AI alone. Unfortunately, now there have been a number of studies, including one of my randomized controlled trials, that shows this isn't the case. This is from a Google study here. I had nothing to do with this study. That's my my disclosure. But you can see like the LLM by itself outperforms humans using the LLM, meaning that humans degraded the ability of the LLM to make complex CPCs. Again, these are CPCs. So how meaningful is that? Well, part of the problem is that my group then run 2 randomized control trials where we randomized physicians to use AI to solve complex management and reasoning cases. And then we used very sophisticated measures of clinical reasoning. We also looked at diagnostic accuracy. And unfortunately, we found the same thing, which in diagnosis, using an AI model did not improve the diagnostic accuracy of doctors. And in fact, the AI model by itself did better. This is on the left. And you can see O1 on the far left also does incredibly well. No statistical significant difference, but you don't need stats to actually see the reason is it's just been saturated, right? You can't get any better than this. O1 is basically perfect at this task. Now, the study that really freaked me out is this one on the right. These are management cases for which there is no right answer. So to make these cases, they are multi-part, multi-step cases. I paid 25 subspecialists, so 5 subspecialists for each case, and there were 5 cases, to come up with not only the cases, but very complex rubrics. Again, no right answer for any of these. And you can see on the right, the purple box all the way on the right, physicians do a pretty wide distribution, averaging about 40% accurate. The AI here actually did make the humans better, so yay. However, if you look at what it made the humans better at, it didn't make them better on like what's the right dose of a DOAC. It made them better at like apologizing after making a medical error, or like a patient has an incidentally found lung nodule that's likely cancer. How do you communicate to that family and do appropriate follow-up? So it made humans better at the things that we think of humans as being good at. It didn't make them better at the things that we think of machines being good at. Now, what really freaks me out here is if, again, you look at O1 in the upper left, O1 just is saturating these benchmarks also. Like it truly is superhuman performance in a way that, again, kind of freaks me out. It should not be this good. And then, one of the very interesting things about my field, and that Alex actually mentioned going through this, is that I think, Alex, you said multiple times, oh, it makes me feel more confident, right? I am happy that it's agreeing with me. And what's really cool and a little bit scary is that we found that language models have many of the same biases as humans. And this isn't that controversial if we talk about the racial biases that they have or the gender biases that they have, but they also have cognitive biases, and like they anchor on things to a similar degree to humans. And you can already see how this could drive people astray, because who's putting the information into the language model? Humans. So if you're putting the information in and the model has a tendency to be sycophantic and anchor, it might just give you false confidence. In fact, when we dig into the data from our randomized control trial, this is part of what explains the data, which is that very few humans use the model to critique themselves, to say how it could be wrong. And many more people just felt assured, sometimes inappropriately assured, when the model agreed with them, because of course they are the ones prompting the model. Some other exciting data, and now this is where my COI kicks in because this is my team at Google, even though I had nothing to do with this study, is that increasingly we're finding that language models can collect data, i.e. take a history. This is Ami from Google. There's also Mo, which is from Allen Health in France. Both of these models showed that when now these are not real patients, well, Mo did do real patients, but when they studied it experimentally, these are actors, standardized patients, patient actors. So in a true Turing test, you don't know whether you're talking to a human PCP or a computer. The AI model does a better job of taking a history. Patients liked it more, and it makes more accurate diagnoses. In 28 of 32 axes, the computer beat the humans, tied in the rest. And then from the patient perspective, in 24 of 24 axes, so 100% of the time, they preferred the computer to the human. So we're finding, again, I'm not that surprised, but we're finding that these models also in limited domains are able to collect data in a human-like fashion or superhuman fashion. Now, all of this is happening. Like I do research that I think is really cool, but is not really having any sort of clinical effect. So all of this is happening in a milieu where LLMs are being aggressively launched into healthcare settings. And I don't know if you guys are using these at Prov. We are just starting using this at Beth Israel now. So we have ambient listening, right? And then patient portal communication. So patient portal communication is where the AI writes the first draft of your portal messages, which are something that I think not many of us particularly like, right? They're really, the constant amount of time spent in the portal is a detriment to many doctors. We've rolled this out at some of our clinics at BI. Now, if you've read the news or if you've used this yourself, what you probably have realized is that it doesn't actually have the time savings that a lot of the vendors promise. Read time is higher, reply time is unchanged, length is higher. And Jonathan Chen had a study, and same study here in RadOnc, that like the reason being like 7 or 8% of these portal messages are just inappropriate and sometimes dangerously slow. So humans have to go back and edit in a way that eats up any time savings. Ambient listening is the other big thing in which there's a lot of excitement. At BI, we're starting to roll out Heidi as the technology. The big Epic integrated ones are DAX and Abridge. Again, the data is pretty similar. The vendors would have you think there are going to be huge time savings. When we study it, the time savings are heterogeneous, and if you look overall, there usually is no time saving and no efficiency saving to using ambient listening technology. Again, because they hallucinate and doctors have to go back and change things. Though you will find that both of the big studies in this field showed that both patients and doctors like it because, people just look at each other instead of typing over a keyboard. So this is an example where even if the technology isn't there yet, it probably is going to continue to get better. And there is a huge drive in health systems across the country to use this technology in particular. Okay, so this is where I want to turn it over to questions from everybody because what I want to answer or what I want to ask for you is, this is the data, you can see how it works, but what does this mean for the practice of medicine and what does this mean for medical education? So that's it for my presentation, and I will take any questions that you guys have.
Great, thank you so much, Adam, including the real live demo. So one question that has come through already is, if we moved towards AI in clinical use, will human doctors lose the ability to recognize AI errors?
So yeah, this is the idea of cognitive de-skilling. I don't think that I will, or you will, or Alex will. Like, we have brains that have been trained on the old system. And this gets back to the cognitive theories of learning. We know how to train a good doctor, and it's not pleasant. It is supervised learning. It's making mistakes. It's seeing things over and over again. It's getting feedback. And the concern, and this is something that we're worried about at Harvard, is our medical students are coming in having already used ChatGPT in their undergrad studies. They're routinely using it right now as, in medical school. The technologies, ChatGPT, like especially if you're using the free version, it's okay. It's not great. It's probably more helpful in the hands of a skilled physician. But look at O1. We just looked at O1, and then imagine future technologies. They're going to be really good at making diagnoses. Students are going to use these from the first day of medical school. How are they going to learn to build those cognitive skills on their own? And then to the question, Laura, is how are they going to learn to second guess the AI when it's wrong in a way that all three of us can, because we have like old sorry that I keep calling us old, but we have brains that are trained in the old system. And that question to me gets at the heart of what do we need to do in UME right now, and we don't have a lot of time to make up those decisions. My guess is that there's going to be a move to restrict the use of diagnostic tools for the first couple years of residency in particular to build up those skills. Radiology programs do this already, right? Radiology programs will often not allow nodule detection or SDH detection so that the residents can build up those skills. No one has said this yet, but I think that's almost inevitable that it's going to come there.
Great, thanks for your thoughts. Let's see, here's another question coming through. When doctors make a mistake, we potentially get sued. When AI makes mistakes, either by themselves or with a human, who is responsible?
Right now, the human, no matter what, it's us. Now, that's because of the regulatory pathway. So there is a regulatory pathway for static prediction models called software as a medical device that the FDA has created. I don't think it works that well, but that is a pathway by which the device creator would get sued because it's a medical device rather than the doctor. The FDA, I've had a number of conversations with regulators. The FDA would like to create a regulatory pathway for these technologies that would create a future where it's not just on the human doctor. That does not exist yet. So even right now, if we have a super powerful model that can outthink you and you use it, and you make a mistake of it, you're still going to get sued. 10 years down the line, I don't know the answer, but the regulatory future is incredibly unclear right now is a polite way to say it. And I don't know if this intentional gray zone will go away, or we're going to live in this very strange world in which doctors basically exist as liability sponges, or the moral crumple zone is what it's called in the literature. Like, I don't want to be a moral crumple zone, but unless we change something about how we regulate this technology, that's what's going to happen to us. Sorry to be depressing.
Is the reality. Thank you. I'm trying to think through a question here as you're going through this case and as I think of others, particularly as a general internist and maybe also in the primary care setting. It is rare, I think, that we see a person who has a singular and unique, interesting diagnosis. Often there are many intersecting pieces with multiple diagnoses. I wonder if there's any thought about that in AI and including in the studies with regard to what success looks like.
So, and you're raising a really good point about the research and the research benchmarks and why, for example, CPCs are a terrible benchmark. Like, I would rather take a system that can recognize the nuances of different neurodegenerative disorders than something that can like diagnose IPEX syndrome. That is not a cognitive task that I deal with frequently, and quite frankly, like, that's fine if it can't do that. Now, this is a power of LLMs versus earlier differential generators, which is that they are capable of having this nuance. So the tech can do that. I think this gets to how we study it and what our benchmark should be. We currently have historically had benchmarks of tough diagnoses. Why? Well, internists are kind of like, we pride ourselves on making tricky diagnoses, so we've set those up. But also, like, no one, if you go back to like the original papers, Ledley Lusted, no one ever thought that computers would be able to do this for a long time. So it was okay to have those benchmarks. We're now in a world where we need to start studying these technologies. And this is, I can't talk about it, but this is the work I do at Google, right? Google doesn't care about like making those complex diagnoses. They care about it being useful for our everyday, like the million variations of COPD, or like when somebody's anxiety disorder is affecting with their ability to manage their diabetes. I will tell you, language models can do that very well. It is up to researchers like me and my colleagues to come up with reasonable ways to measure that. And more importantly, probably we need to do more. And I'm running a clinical trial now. So like when people tell me we need more RCTs, I want to strangle them as if like if they knew it is so hard to run RCTs. I'm doing it, but we need more clinical trials. And because of that, we need more, we need funders to fund these sorts of trials, because it's not the tech that's the problem. It's like the trial infrastructure, it's the people.
Yeah. Great, thanks. I'm going to try to squeeze in one last question here. What about the patient that just doesn't look good?
Yeah.
Are there limitations of using only language and data? Is there a way to feed AI this information, sort of the gestalt, ooh, this person's sick?
Amazing question. So right now, language models and their architecture work best with language. There are multimodal models. Everyone has used them. I have a study at Nature Med that looks at this. They're pretty much just exploiting text. So a lot of what you see with these fancy multimodal models is a mirage. They're getting better, but they're not there yet. So this idea of like the robot doctor will see you now and do all these things remains science fiction. And for the time being, we're not going to get the patient, you know, the kind of intuitive you look through the door when you're like, oh, something's bad here. Now, language models, we've been dealing with just language models, and I said multimodal. So what is increasingly going to happen over time is that we're going to have models interacting with other models, with other type of predictive models, with other type of vision models that are going to allow for a more comprehensive view of the patient. Will that replace human intuition? I don't know. I like AI is. We all have these models where we imagine like Mr. Data from Star Trek, but that's not what these technologies are like. They're text-based. Their intuition comes from human language and like force structure of human language. I honestly don't know if we can ever replace that human cognition, which is why I think the future of human-computer interaction looks so weird, because I think we're going to be in a situation where a lot of diagnostic tasks will be done by AI models and ordering tasks, but a lot of this like management reasoning, including that basic like this person's sick, I don't know how good they're going to be, and a lot of that is still going to fall on humans. So I think we're going to look at a hybrid model of reasoning that still is very human based, but in particular on the things that humans are good at, and like that person looks bad, I think is a very human feature.
Well, Adam, we live in an interesting time. Thank you so much for your work on this space. We are at 9 o'clock, so I'm going to wrap us up. Really appreciate you giving today's Richie Warnick lectureship.
And anybody who wants to reach out, feel free to send me an email. It was great talking to all of you. Have a wonderful day.
Awesome.
Bye, everybody.